The next day, the first day nurse who we had told us that she had called over to Children's Hospital across the street and that the nurse from the Craniofacial Center would be coming over to take a look at the baby.
I like to make the contact with the parent in the maternity hospital, either by phone or by visits if they're close enough. And that's extremely important to do that so that they know that there's someone out there they can talk to. They know that it can be taken care of, and they're not going to be out on a limb someplace looking for people to help them.
I remember early on one of the concerns that we had was, how are we going to feed this baby?
Many of our healthcare professionals, again, because they haven't worked with enough cleft children, aren't up to date on what types of feeders work, how to feed the child. Unfortunately, today we have some special feeders that are very easy to use, and they just a couple little techniques, and the mother can be an expert feeder. The father can be an expert feeder.
I
sort of
get it.
feel
There
the
he
rhythm.
goes.
Yeah.
One of the first things that we'd also heard is to pick the hospital we'd be working with. And in Boston, we had a choice of two. And we set up interviews immediately with both of those places to interview with their team. Both hospitals had teams in place that covered all sorts of issues, dental, surgical, speech for later on, things we hadn't even begun to think about.
The four major concerns in the child born with cleft lip and palate are, and I will not give them in any particular order, are the appearance, obviously, the nose and the lip, and the overall appearance of the face in time as the jaws grow, speech, the dentition, and the hearing. And every cleft lip and palate center has people devoted to these four areas of interest.
Well, there's a whole spectrum of cleft types. It's not fair to categorize anybody and to say if you have this kind of cleft, it's this kind of treatment. And that's really what the focus of the whole early treatment planning is to look at that person and to try and figure out what's the best way to go about treating their cleft.
There are two major categories of clefting. One is called cleft lip palate, and the other is isolated cleft palate without a cleft lip. Cleft palate is concerned only with speech, sometimes with dentition, but is involved with middle ear disease and frequent infections. Cleft lip, cleft palate is a broad spectrum. You can have just an isolated cleft of the lip and little changes in the nose, or you can have the cleft extending through the gum and into the palate. In terms of cleft lip, you can have a cleft just on one side or a cleft on both sides. If it's both sides, it's called bilateral cleft lip. If it's just on one side, it's called unilateral cleft lip. And then the unilateral and the bilateral can be divided into complete forms, and where the cleft extends into the nose through the floor of the nose, or you can have an incomplete form and where there is some band of tissue at the top of the lip holding the lip together.
We initially thought all we needed was a surgeon and we'd be done, but then the dental issues arose during the first year. We know that there will be orthodontic issues.
Obviously, parents' first concerns are surgical, but pediatric dentists are concerned with the development of the dentition from birth through adolescence. Our perception is that a cleft of the lip is one of the lesser forms of cleft lip and palate. But a parent should sense from the outset that clefting of the lip alone with no involvement of the dento-alveolar complex is very unusual. Almost all cleft lips, therefore, involve the gum and the ridge from which the teeth come.
The teeth seem to be a reasonably good focus of attention early on. So we're always asked, are the teeth going to be normal? Are they going to have a tooth in that spot? So when they get a little bit older and instead of having a tooth in the cleft line, they just have the cleft or a tooth that's out of position or not too well formed, everybody wants to know if there's going to be a normal tooth there in the long run. And the answer is always yes. Oftentimes, early on, it's too soon to say which tooth or whether we need to have a replacement tooth or what kind of replacement tooth is going to be. But there's always going to be a tooth in every spot, and it's always going to look good. It's just a question of which is the best choice.
There are other physicians of other specialists who are involved in caring for these children. That includes, for example, an otolaryngologist or an ENT person. You need a speech pathologist. You need a whole host of specialists who make up a cleft lip, cleft palate team.
An individual who is born with a cleft palate have problems with their ears, which are much more frequent than the general population. And the reason for this is the tube that goes from the back of the nose to the ear, we call it the eustachian tube, doesn't function very well in people who are born with a cleft palate.
When that occurs, there can be often fluid buildup or ear infections in the cleft palate child, and these can cause varying degrees of hearing loss.
Now, with a systematic follow-up of these individuals, we can prevent these complications so that ear will be functioning properly. It'll be a normal hearing ear, and that's what we want to attain.
Speech pathologists and plastic surgeons have now worked together for years in order to understand the nature of early speech and language development and the outcome of repair at different ages. When a child is born without a cleft palate, there is a full palate there, hard part and a soft part. And you can put your tongue in your own mouth and feel in the roof of your mouth where it's hard in the front, there's a bony structure there, and where it's soft in the back. Where it's soft in the back is where the muscles are. And in normal speech, those muscles will rise up and push way to the back of the throat to close off the nasal passage while we're talking. This is very important in order to have a normal sound to your speech. And the child born with cleft palate is not able to close off the nasal passage during speech. Parents should understand that in all likelihood their child's speech will develop normally, but this close monitoring is a very important component of their development.
Because of all these different factors that play into the proper treatment planning, it takes a very forward-looking, not person but group of people to really come up with an appropriate treatment plan.
So the team is about talking, meeting together, seeing the patients together, exchanging our own ideas of what the major or the minor needs are and how we're going to get there together.
You're just going to feel more comfortable that you're not getting conflicting opinions from all these different people about when surgeries should be scheduled and what the right prognosis is and what the right devices are. I mean, it makes intuitive sense to me.
There's a reason 50 years of team care, more than 50 years of team care in the United States. There are 250 about teams in the U.S. There's a reason that structure has endured. It's because it makes such sense, and it works so well.
And there is a list of these cleft lip and palate centers that can be obtained from the American Cleft Palate Craniofacial Association.
There are also cleft lip and cleft palate groups throughout the country that will be more than happy to provide you with names of the various cleft palate teams so you can seek help that way.